So today, as all of you know, that day by day, the longevity is increasing. That's a good thing. But along with it, by leaps and bounds, we are having degenerative problems, be it may cardiology or if in orthopedics, also in ophthalmology. So that means all across all the specialty, we have various degenerative problems, and these problems are going to increase. In orthopedics especially, because I am an orthopedic surgeon, I need to talk and tell you that we have at the moment almost 30 million people suffering from either rheumatoid or osteoarthritis. And this, of course, number is going to increase. This is not exactly, we do not have a statistics, but I am sure this number will be more. And they claim, the statisticians claim by year 2015, we are going to have practically 100 million people who are going to serve to have this disease. And this is a huge disease burden, not only on the patients, but also on the healthcare industry. And this is what gives us an impetus to start something new. The innovation, especially to reduce the suffering. We may or may not be able to cure this disease, but at least alleviate the problems which are there in the patients. And this is what I'm going to talk about, the newer molecule. And my whole lecture is going to be about the disease burden which I spoke to you about. The pathophysiology, which I am going to tell you in simple terms, because it's not going to be extremely easy to understand this. At the same time, what are the current options that we have and their limitations and role of novel anti-inflammatory agents. And this is what we are going to talk in brief today, because I know it is already 10:30 and you are feeling hungry. So all of you know that rheumatoid arthritis is a dreaded problem and disease. It is a systemic disorder characterized by chronic inflammatory polyarthritis of unknown etiology. We really do not know what is the etiology, what is it that triggers this problem. And unfortunately, this is an inflammatory problem. Along with the joints, it also affects skin, eyes, lungs, and blood vessels. And that is the real unfortunate or the unlucky people who have these problems. It has a fluctuating clinical course and unpredictable prognosis. Unfortunately, with all these cardiologists who are here today, we also have to share that almost 60% of this, there is an increase of risk of CVD-related deaths. And also, there is a complex and multifactorial pathogenesis, which really makes it really difficult disease to treat this. I'm going to also give you a small 3-minute video, which in case, because there is an accent which is in British accent, I may be able to give you a little bit of brief about how these things works. Can I have the sound, please?
The pathologic hallmarks of rheumatoid arthritis include inflammation of the joints, particularly the small joints in the hands, wrists, and feet, accompanied by cartilage destruction and bone erosion. Underlying inflammation leads to many of the characteristic signs and symptoms of RA, such as pain and swelling of the joints. Inflammation results from abnormal propagation and activation of many types of immune cells, resulting in the secretion of cytokines and other mediators that sustain and amplify the inflammatory environment. As a key pro-inflammatory cytokine, TNF-alpha, along with other cytokines, activate immune cells, including macrophages, as well as other cells such as synovial fibroblasts. In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1 and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs or matrix metalloproteinases. Thus, activated cells in pannus are key instigators of cartilage destruction. Chondrocytes are the main cellular component of cartilage and normally produce the extracellular matrix. However, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha, and rank ligand, osteoclast precursors differentiate into mature osteoclasts, resulting in bone resorption. Thus, the direct and indirect effects of the TNF-alpha on osteoclast maturation and activation culminate in focal bone erosions and irreversible joint damage.
So after this Star Wars-like science fiction movie, I would like to translate this into simple English. Basically, rheumatoid arthritis is activation of macrophages by antigen-presenting T cells and other cells. So it releases inflammatory cytokinins, basically TNF-alpha and interleukin-1. And this TNF-alpha and IL-1, this leads to synovitis, production of collagenase which destroys extracellular matrix, and release of MMP, that is matrix metalloproteinase, leads to cartilage degradation. So basically it's synovitis, cartilage degradation, which happens in both kinds of osteoarthritis. In arthritis, whether it is primary or rheumatoid arthritis, both these things are possible, but in osteoarthritis we have, along with TNF-alpha and IL-1, we also have IL-6, IL-17 and MMP. So this releases the pro-inflammatory cells, damages the synovium, and then ultimately the cartilage degradation occurs. So this pathophysiology is basically the same, but at the same time, this major inflammatory cytokine involved in RA and OA is a basic problem. And before that, the release of this inflammatory cytokine is regulated by nuclear factor kappa B, in short NF-κB, and this is really an important progenitor or starting of this inflammation. This is what is extremely important, and NF-κB plays an essential role in inflammation and immune response. So this, you can say that this is a master switch to the inflammation, whether it is on or off. Once it is on, the inflammation starts. And that's the reason why any disorder due to NF-κB activation will lead to rheumatoid arthritis, osteoarthritis, or we can have ankylosing spondylitis, psoriatic arthropathy, and also juvenile arthritis. So NF-κB is a master switch of inflammation that all of us should know. Maybe at the end of the lecture, I think couple of messages that you should take. This is one thing. And now we'll see how the whole activation of NF-κB occurs. The inflammatory stimuli which stimulates the TNF-alpha, IL-1, etc., which activates the NF-κB, which also gives the translocation into a nucleus, activates the genes encoding inflammatory mediators, and this gives rise to pro-inflammatory cytokinase, inducible enzymes. This releases inflammatory mediators, and that causes all those problems which are related to arthritis, whether it is rheumatoid or osteoarthritis. Basically synovial membrane, the chondrocytes which gets degraded in the bone, which is because of the osteoclastogenesis, and the bone erosion starts eroding. And this is exactly is very important. So NFKB plays a crucial role in inflammatory and immune response through the regulation of genes encoding pro-inflammatory cytokinase and inducible enzymes. So this is basically a pathophysiology which is very important, and this was the toughest part of this lecture today, which probably I think I have been able to tell you in short by this video, etc. So now, what is an innovative option for the management of arthritis? This is one thing, nuclear factor kappa B, that has to be inhibited somehow, and that is what is our goal. So curcumin is a molecule which is a very, very innovative and excellent molecule, which is biologically active phytochemical compound obtained from rhizomes of Curcuma longa. So many of our products, whether it is in cardiology or in orthopedics, have basically come out from a herbal this thing, whether it is digoxin in cardiology or this Curcuma longa, which is an excellent product supposed to be and shows a lot of promise in future, possesses diverse properties of anti-inflammatory, antioxidant as well. So this is a basic NFKB inhibitor which controls NFKB master switch of inflammation. This is what you have to remember. And this, how does it act? In which site? It acts on multiple sites. First of all, it prevents the activation of NFKB by inhibiting the IKB. So obviously, the second stage does not take place, and it prevents the translocation into the nucleus. And third, it prevents the release of inflammatory mediators. So all these three pathways are inhibited by this curcuma. And then let's see what is the evidence for this. What is the role of curcumin in rheumatoid arthritis and osteoarthritis? So there have been lots of studies which have taken place and which has come after this molecule has been evolved over a period of time. So they have compared this curcumin with diclofenac, and the curcumin provided greater improvement in disease activity score known as DAS and American College of Rheumatology scores as compared to diclofenac. And what we have concluded is curcumin is effective and safe in patients with active rheumatoid arthritis. Then another study, a pilot study in curcumin, when 18 patients with rheumatoid arthritis were treated with curcumin for 2 weeks. Mind you, in 2 weeks, curcumin improved the joint swelling, morning stiffness and walking time. So it is very well tolerated and has a better GI tolerability. It is very effective and well tolerated. So you can see that this result or this effect is seen within 2 weeks, and that's a wonderful thing for all of us physicians. So in osteoarthritis also, real life experience with curcumin monotherapy. So it is curcumin which was given only to 820 osteoarthritis patients attending outpatient clinics were treated with this for 6 months, and the results were this provided significant improvement not only in pain but improved joint flexibility and better quality of life. 50% of the patients were able to discontinue use of NSAIDs and analgesics, and the therapy was very well tolerated. That's excellent. So it relieves pain and reduces need for NSAIDs in osteoarthritis. There is one other study in which 367 patients of knee osteoarthritis with pain score of more than 5 were randomized to receive ibuprofen or curcumin for 4 weeks. So they were given ibuprofen or curcumin, and this was randomizedly selected. So there was significant decrease in WOMAC pain, stiffness and functional score from baseline in both groups. So it was concluded that curcumin is as effective as NSAIDs but has a better GI tolerability. There was another study where 100 patients of OA were treated with curcumin for 8 months. 8 months is a long time. And the results were significant decrease in serum inflammatory biomarkers. So that is IL-1, IL-6 and what have you. All those were reduced. 50% there was a decrease in WOMAC score. That is again a pain score that we generally check. And there was a 3-fold increase in treadmill walking performance. So basically the patient's joint flexibility increased, the pain reduced, and patient's ability to do work was also more. So in patients who were already on NSAIDs and analgesics, co-administration of curcumin was associated with decreased need of NSAIDs, marked reduction in GI side effects. So it is extremely useful. Not only that, it is effective in long-term treatment management of osteoarthritis, and that is very important. As you know, there is no real treatment or a cure for osteoarthritis. We need to give these drugs for a really long time. Then there was a combination therapy of curcumin with diclofenac. This is another study where 44 patients each in 88 patients with the primary osteoarthritis were treated for 3 months as compared to diclofenac monotherapy. Combination of curcumin with diclofenac was associated with greater pain relief, better improvement in knee injury and osteoarthritic outcome score. So basically it has additional effect if given with NSAIDs in the beginning. So this combination therapy of curcumin along with celecoxib, that it enhances the action of celecoxib or on COX-2, decrease the need for celecoxib. When it is given in combination with prednisolone, it has significantly reduced the side effects of steroids, also reduced the joint swelling and anti-inflammatory action through inhibition of inflammatory cytokinase. When it was administered with methotrexate, which is the drug of choice in many of the rheumatoid arthritis, it provides synergistic anti-arthritic action, may help to reduce dose of methotrexate and reduces the risk of hepatotoxicity and hematological toxicity. And this is very important, especially when we are giving methotrexate. This is an extremely dreaded complication that we see. So this, coming to the safety, it is generally recognized as safe, that is called GRAS by US FDA. No noticeable adverse effect was observed with doses up to 8 grams daily for 3 months. Unlike NSAIDs, free from adverse effects on kidney, liver or CVS even after long-term use. Occasional patients may complain of mild or transient nausea or diarrhea, and that's the only adverse reaction that has been seen with this. So unlike NSAIDs, steroids or DMARDs, curcumin is very well tolerated even for the longer period of time. So the Cadila has come out with a novel formulation of curcumin, but at the same time we have to actually find out what this molecule that the Cadila has come out with. See, basically a conventional curcumin which has also been used in the past, it is poorly water soluble, polyphenolic compound, poorly absorbed from the GI tract. It is undetectable in plasma, doesn't reach systemic organs or tissues. So we really do not know about the efficacy of this. The clinical trials carried out with conventional curcumin, they have used up to 12 grams per day. Few studies have not shown positive results, and there is a poor GI tolerability. So there was a need for bioavailable, effective and well tolerated curcumin formulation, and this is an essence, and this is where Cadila has scored. So now this is a bio-enhanced curcumin which is there and which has been done, which has been formulated by SMEDS technology. What is this SMEDS technology? Which is a self-micro-emulsifying drug delivery system. And what does it do? This technology provides a nano-sized hydrophilic droplets of curcumin. It improves the absorption and better tissue penetration. And this is how this chart or this figure shows you how it gets bioabsorbed very well with a lesser dosage. So this bio-enhanced curcumin, the human pharmacokinetic study has shown that it has higher bioavailability with a less dosage also. So this bio-enhanced curcumin, the dosage is, of course, it varies from patient to patient depending on the disease severity, degree of inflammation and patient response. Majority of patients with mild to moderate inflammation usually respond to 100 to 200 milligrams per day. If required, one can increase the dose up to 400 milligrams, and that's what is required to really get the disease in control. So in summary, bio-enhanced curcumin, it inhibits the master switch of inflammation, that is NF-κB, decreases the release of inflammatory prostaglandins and cytokinase, that is all TNF alpha, IL-1, IL-6, etc. The monotherapy has found to be very effective and safe in treatment of rheumatoid and osteoarthritis. Efficacy at par with NSAIDs, but with better GI tolerability. In fact, there are hardly any adverse reactions which were seen. It can also be used along with NSAIDs, steroids, provides additive synergistic action and helps in the reduction of dosage of each of them. Can be used along with methotrexate, helps reduce the risk of hepatotoxicity, and unlike the biologics that we have now for treatment of this rheumatoid, which are unfortunately given parentally, and at the same time it is extremely expensive, and some patients have shown some adverse reaction to IV also, and they have to be really monitored well. So this can be given orally. It is extremely safe and well tolerated. So it is a suitable option for monotherapy as well as combination therapy. So this has bioenhanced curcumin has a place in therapy. It is an attractive option in management of rheumatoid arthritis and osteoarthritis, either as a monotherapy or combination therapy. Extremely important, particularly useful option in following groups of patients. Those patients who are intolerant to NSAIDs, steroids or DMRDs, those with a compromised renal functions, those with hepatic dysfunctions, and those having CV disorders like hypertension and chronic heart failures. So it is effective, safe and well tolerated treatment option. And as you know that all of us orthopedic surgeons are not very much keen to give medicines. We are, as surgeons, would like to operate more and more. But the disease burden is so much that even if we operate 1 lakh or 100,000 knee replacements every year, we are never going to be satisfying the patient's needs of India also. So that means there are almost 3 crores patients with different levels of disease at the moment with knee problems in India. So we will never be able to manage them surgically. So we have to ultimately find some medical solutions to at least control this or to prevent the further progression of disease. So in short, I have given you a brief outlook, and all of us are looking forward to the patients relieving pain. We are also looking for patients having a normal life as much as possible, whether it is cardiovascular or cardiologist or us orthopedic surgeons. So basically our endeavor is to give some kind of medicines which will be well tolerated, with the least adverse reaction and giving good results at the end. So friends, I think this is a wonderful molecule which we can all of us give in future, and I think this has a wonderful, great promise too. Thank you very much.